So the first question was, if the correct surgical site infection prevention measures are applied in the perioperative period, why do some of the patients still develop a surgical site infection? If I can hand that question over to you, Dr. Smith.
Of course, thank you. It's a really good question. I mean, I think one of the slides in my talk obviously had lots and lots of different factors, and several of those are modifiable, and we can address those as part of the care bundle. Some of those are non-modifiable. So some patients who have been smokers for the last 40 years, who are obese, who are elderly and frail, those factors, no matter how good your care bundle is, you're never going to eliminate all of those. So particularly in vascular surgery, we have lots of people with poor blood supply, and the impact of all of those factors is what leads to an SSI rather than just the ones that we can address. So you can reduce the risk of SSI by addressing everything that is addressable. Sadly, you can't change the patient you're operating on. So there will always, regardless of how good your infection prevention and control is, you will always see some surgical site infections because of the nature of the intervention, sadly.
Michelle, could I add a couple of practical pointers to what Dr. Smith has mentioned?
Please do. Thanks, Helen.
Okay. What I would like to say is when we refer to the risk factors that make patients vulnerable to healthcare associated infections, we talk about endogenous risk factors. So those come with the patient themselves, and you've seen the many that George has listed on his slide. And then we talk about exogenous factors, and that's what comes from outside the patient, the environment and the healthcare service. On a practical level, I would just like to mention that diabetic patients have sluggish leukocytes, polymorphs and macrophages, and clinical studies have shown that these patients, when they're due to enter the second phase of healing, the inflammatory phase of healing, they're not able to mount an effective inflammatory phase of healing. And another very big risk that we're seeing clinically is patients that have been on long-term non-steroidal anti-inflammatory agents. And sadly, this is, I think, possibly one of the reasons why we're seeing a lot of orthopedic and joint patients succumbing to wound infection, you know, sort of 10 to 11 days post-operatively, because they too are unable to mount a good phase 2 of healing. And then the third one I'd like to mention, and this is for the nurses and the wound care practitioners in this group today, urinalysis remains very, very important for your patient. And given all the things that we have to do nowadays and all the paperwork, this is something very important that tends to get missed. And it's almost like the CV of your patient. Please don't neglect to do a dipstick urinalysis on your patient, because very, very often a source of infection elsewhere in the patient's body can predispose that patient to wound infection. So, and this would include your surgical site infection. And then the other thing I would like to say in terms of endogenous risk factors, and something that I'm seeing in my practice because I have to assist with medico-legal cases, and that is the poor standard of post-discharge advice that patients are given when they leave hospital after a surgical procedure. Generally speaking, you know, an occlusive dressing will be put on in theatre, as George has mentioned, and that provided there's no problems with exudate and leakage, the surgeon will instruct the nurses that this dressing is not to be tampered with until the patient comes back to see me for their post-op visit. What is important in terms of our patients that are high risk, for example, the ones that have been on non-steroidal inflammatory medication, cancer patients, patients with rheumatoid arthritis, diabetics, obese patients, these high-risk patients need to be informed that if they produce a lot of exudate post-operatively once they go home, bearing in mind that in the private sector, funders, as well as in the state sector, pressure on beds, patients are being discharged before the second phase of healing initiates, which is 3 to 5 days after surgery. And some of these patients, occlusive dressings will leak. And what is happening is they are packing these wounds on top of that polyurethane layer. the wounds are macerating and then they are dehiscing and breaking down. So I believe we should improve the quality of our post-discharge advice regarding exudate management in high-risk patients. Thanks, Michelle.
Thanks, Sister Helen. If I can go to the second question, what are some of the innovative initiatives that one could advise in terms of preventing the so-called stewardship fatigue, especially when it comes to the low-hanging fruit? I think that's my cue. So I don't really know if this was Albert Einstein, but and relating it back to stewardship fatigue, about the definition of insanity is doing something over and over again and expecting a different result. And similarly with the low-hanging fruit, basically for me, there's two scenarios. And the first one is if in your facility, you've implemented some sort of project or initiative that's working, right? And you're seeing these good measurable outcomes, you're seeing the data, things are working out really well, everyone's on board, then my suggestion is you stick to it, right? And you don't tamper with that project or initiative. The important thing is that you ensure that any new member on the team, whether it's from a management level, whether it's at nursing, whether it involves the pharmacy, you must induct that new member on your project. They must be well aware of the intentions and the successes of that project. And this is to ensure continuity, right? The second thing is that even though your project might be successful, it's important that you still audit and feedback. So when people look at these, the data results and they look at the information that you're sharing, they're more likely to continue investing and keeping to those elements or initiatives that you've put into place to ensure appropriate prescribing, for example. For me, the second scenario would be is if you've tried something over and over again and it's just not working out, you're not seeing the results you would like, okay? For me, unfortunately, the example here is surgical prophylaxis. So surgical prophylaxis is something that we've been battling with for years on end, and we're still not getting it right. And the big argument comes up is that, you know what, it's a single drug, it's one dose, why can't we get it right? And obviously the guidelines are readily available to everybody. They, you know, everyone has access to them. So it's evidence-based guidelines, so why can't we get it right? So using surgical prophylaxis as an example, you need to think about a multimodal approach. So it's not it's not a single thing that's actually going to, where you're going to see results. So my advice specifically with surgical prophylaxis is getting that medical rep involved. She must set her table up, obviously COVID protocols, taking into account your COVID protocols at your facility, but setting up a table outside theater, engaging with your doctors, your scrub sisters that walk in, engaging with the anaesthetists on the correct use of our surgical prophylaxis in our patients. The second thing would be to have training with your scrub sisters, because at the end of the day, they are the ones going to that cupboard, taking out that cefazolin 1 gram and handing it to the doctor that's going to administer it to a patient that's 120 kgs. But if you empower them, show them the guidelines, show them the data, and why you're suggesting that 2 gram or 3 gram dose, so that when the doctor requests the drug, they can have that sort of discussion with the doctor. Obviously not a lengthy discussion, given the fact that the patient's on the table, but I mean, have those sort of discussions. The third thing would be is to focus on your anaesthetist, because often than not, and in my experience, when you call the surgeons to query a specific antibiotic dose, they will say, no, but it's the anaesthetist, it's not my script. So to have a focused approach, with just having your anaesthetist in one room or in a webinar where you address them, share the data, and not just international data, or, you know, it's got to be data that's specific to the facilities in which they work. And I think it hits home because you sort of show them, you know what, this is what we're doing. We're seeing an increase in our surgical site infections. This is what should be done, and this is the guidelines to support what I'm saying. So just to re-emphasize that it's actually it's a multimodal approach. There's no single cure for any of these sort of things. So good luck to all of you with these low-hanging fruit. Okay, moving on to the third question. How can we get IP and pharmacy to work more closely together? Helen, I don't know if you would like to also comment here before I do.
Yes, thank you, Michelle. You know, it's a multifaceted approach, and I believe, and I believe one of the basic faults in our clinical situation in our South African hospitals, it would appear in most hospitals that the infection prevention practitioner is not trained in and is not aware of wound care. It's not involved in wound care in any way. And I think that's a very big weakness in the system, because given our setup in both the state and the private sector, the chief pharmacist or the senior pharmacist very often have a say over the kind of wound dressings that are purchased for that institution and for the budget in that institution. And I believe that it should be a fundamental requirement for infection prevention practitioners to be trained and have an idea about wound care and the complications that ensure, because it's really when wounds go wrong, that's when you actually see the drug resistance and you see the pain and suffering that our patients and our families encounter. So in my practice, one of the first people and one of the first relationships that I would see to it that I built on when I was new in a hospital would be introducing myself to the pharmacists and indeed whoever was responsible for procurement or having an influence on procurement. And indeed, when I had a wound clinic, I would invite the pharmacist, the clinical pharmacist, to come and stick their head in behind the curtain and see what we were doing in the wound clinic, because this is the only way that people can see. And again, I used to find that this had a very positive effect on getting referrals from the surgeons for patients that had surgical site infection, so that they were referred for appropriate advanced wound management when the surgical site infection developed. Unfortunately, the reality is that our patients go and see their general practitioner, or they phone a neighbor or a friend who might be a nurse, and they say, my wound is not looking good, can you help? And then the fun begins, because you get all these remedies and suggestions. Everybody means well, but the patient, and that George's very first slide about that below knee amputation, that is such a good illustrative slide, because by the time the patient is referred to a wound care practitioner, somebody who actually knows what's actually going on with this wound, and by then you've probably got drug-resistant organisms in there, etc., the patient has used all their resources, and there's very little left of the pie to be able to render good care. And that was why, just in the time that I had available in my presentation, was to encourage wound care practitioners and those that are outside of the hospital setting to keep a note of the organisms that they are seeing, and to speak to an infection preventionist or a medical microbiologist to get more information on these bugs. Because every microorganism tells a story. It has a past and it certainly has a future. And it's really very simple. This is why with Essity we have an initiative called Microbe of the Month, which tells practitioners where these bugs come from, what are the factors or the environment that they like to live in, and most importantly, what are the modes of transmission or the big yellow taxi that they like to catch to get from point to point B. So I believe, as I say, a fundamental weakness is that our infection preventionists are not involved in wound care in the hospital, and they should be making good relationships with the pharmacists and the surgical stores department.
Thanks, Helen. No, I agree with you. I think no one's going to hold us by the hand and introduce us to these important people. So it's actually our duty to go out there and collaborate effectively to ensure that our patients benefit from this sort of multidisciplinary approach we always talk about. But also from my experience, I think it's important that the IP and clinical pharmacist or ward pharmacists are introduced from day one, that you sit down as often as you can to discuss some of the challenges within the hospital. And I think each one needs to understand each one's intentions and what they would like to achieve within the individual capacities as infection prevention and then as clinical pharmacists. And often when we have these meetings, our AMS meetings, we have our pharmacy presenting on a specific, drug that's being overutilized. And then further down the line, you have IP presenting on your hand hygiene bundles or some of the significant infections in the hospital. But I mean, if the two actually work together, and look, let's be honest, if a hospital has a clinical pharmacist, they're lucky. And then you have one infection prevention nurse at most. And some of these facilities are really big and the problems are also large. So I think it's important that they select maybe the top 3 most pressing issues within the hospital and work together to address those. I always think about UTIs, for example. So where the pharmacist would focus on the drug utilization in that specific unit. So for example, why are we using so much of fosfomycin, or why are we using so much of Augmentin? And then you have IP ensuring for that project period, looking purely at hand hygiene. Are those urine samples being taken correctly? Is it a midstream? Is it the aseptic technique? Are the labs picking up that sample, timelessly? And then when this data is presented to our doctors, for example, it's more of a holistic approach, not necessarily segmented, where pharmacy presents again on utilization and then IP presents on their aspects. It's actually a collective data set that you have. And I think that's the only way. So hopefully everyone that's present takes this back and understands the importance that these two programs need to work together. And that's the pharmacy or the pharmacist and the infection prevention nurse. Okay, are there any final comments from our speakers today? Dr. Smith, Sister Loudon?
No, I don't think so. Just a plea to everyone really to do everything they can. As we mentioned, low-hanging fruit, it's the simple things that often make the biggest difference. So just bearing in mind AMS and infection prevention is always better than cure.
Yeah, no, thanks. Just thanks so much for making the time in the middle of the day. And just to say, George, it's been lovely having you on board with us. Real privilege. Thank you.
Thank you.
Thank you. No, Nadi, I just wanted to say Dr. Smith spoke about a perfect storm earlier on in his presentation. And I wanted to say, the perfect remedy to that was all of us being together on one webinar presenting, something that we all, something that we care about and have a lot of passion for, and that's our fight against antimicrobial resistance. And I think if we just sort of have this mindset and take it back to our areas of work and, really put some effort into it, keep it fresh, we really can make some sort of a difference, and even a small difference goes a long way. Thank you.